The information in this podcast is provided for informational purposes only. You should not use any information discussed in this podcast and related materials to make medical or healthcare related decisions. Always consult your physician or other qualified healthcare provider with regards to diagnosing and managing your medical condition. Any medications or treatments, including any discussed in this podcast, should be initiated and managed by a qualified healthcare professional. Welcome to Long COVID The Answers. Today's episode is entitled Post-Exertional Malaise, or PEM, Long COVID and its Management. I'd like to introduce Professor Todd Davenport. Professor Davenport serves as Professor and Vice Chair of the Department of Physical Therapy in the School of Health Sciences at the University of the Pacific in Stockton, California, USA, where he teaches in the Doctor of Physical Therapy program. He also has a Master's in Public Health obtained at the University of California, Berkeley. Professor Davenport has served on the multidisciplinary primer writing committee of the International Association for Chronic Fatigue Syndrome, myalgic encephalomyelitis, and as a contributor to World Physiotherapy's long COVID briefing paper on safe rehabilitation approaches for people living with long COVID. He is an education co-chair of Long COVID Physio, which has an excellent website. Welcome, Todd.
Thank you. Thank you so much for having me, and thank you to your viewers and your listeners. I appreciate the chance to be here.
Thank you. Todd, do you have any conflicts of interest to declare?
I do. I have the opportunity to work with a lot of talented people. Some of them are at the WorkWell Foundation, where I serve as scientific advisor. I'm also the founder of WorkWell Health, where we do clinical services with individuals who have post-exertional malaise.
Thank you. Today's interview is based on a series of free blogs given by Professor Davenport called Lessons from Myalgic Encephalomyelitis Chronic Fatigue Syndrome for Long COVID, published in the Journal of Orthopedic and Sports Physical Therapy in February of 2022, and also Long COVID Physio video on pacing. Firstly, Todd, what is PEM? Can you explain the clinical staging of post-exertional symptoms?
I can. So post-exertional malaise is known by another term, post-exertional neuroimmune exhaustion. That's really the understanding that I'm following from here with this explanation. And you can find that in the Carruthers et al. Paper in 2011 describing the international consensus criteria to identify myalgic encephalomyelitis. Post-exertional malaise, as everyone calls it, is a constellation of symptoms and signs that follow an exertion. That exertion doesn't have to just be physical. It can be cognitive, can be emotional, can be environmental. And what's most commonly discussed is fatigue, but the fatigue in post-exertional malaise is the feeling of nothing left, not being able to get up. Some people refer to it as bonked, like after a marathon, but the marathon was washing your hair or brushing your teeth. We talk about the fatigue, but there's a whole host of other symptoms and signs that make up post-exertional malaise, like cognitive dysfunction. You hear people talking about it like thinking through jello, so limited short-term attention and memory. Sleep disturbances, that no one with post-exertional malaise that I've ever met sleeps long, deeply, or well. Widespread body pains, causing a common comorbidity to be fibromyalgia. Weakness, numbness and tingling, headaches, even signs and symptoms of illness like viral reactivation, so fevers and swollen glands and sore throats after exertion. It's usually delayed. It can be delayed. The onset of post-exertional symptoms and signs can be anywhere from a day to maybe 3 days after the triggering activity, which really confounds the understanding of what may have caused any given exacerbation. The recovery is prolonged. Our group has shown that failure to recover from an activity within 24 hours is an important marker that differentiates being out of shape from post-exertional malaise. And there's commonly a progressive lowering of functional baseline. So I've heard people with post-exertional malaise talk about this like their world becomes smaller. So maybe they're able to do some remunerative work at first, but that's all they're able to do. They're not able to do social events. They're not able to, engage in the family sphere. Soon they're not able to work as much. Soon they're not able to leave the house as much. Soon they may not be able to leave the bed as much. So there's this progressive shrinking of one's world that happens with post-exertional malaise.
Mm.
Now, as for the staging, there are certain symptoms that begin that we think are more immediate. There are symptoms we think that are more short term and the ones that are more long term. And this is related to our research as well as our clinical observations of many people who have undergone cardiopulmonary exercise testing, which is a form of physical exertion. And the immediate post-exertional malaise is very similar to overexerting, but just extra in intensity and at unexpectedly low intensities, like brushing your teeth or rolling in the bed if you're very severe. These are fatigue. Again, fatigue does not do this justice. People report being disproportionately out of breath, dizzy, nauseous. In short-term post-exertional malaise is a consequence of overdoing things once for a sufficiently prolonged period of time, which may just be a few minutes, or overdoing things repetitively throughout the day or over successive days. And these short-term post-exertional malaise symptoms are brain fog or cognitive dysfunction, muscle and joint pain, headaches, and sleep disturbances. And then long-term post-exertional malaise involves symptoms that last for a week or more and seem to reflect pretty significant physiological dysfunction involving weakness, decrease in function, immune reactivation, and cardiopulmonary symptoms like palpitations and increase in orthostatic intolerance. And so I think the take-home message here is that, post-exertional symptoms and signs are highly unusual. In fact, when I first started working with this patient population, it was just really hard to believe that all of this is happening, but that the patient has a high degree of credibility, and we really should be listening to them.
Really interesting hearing your opinion on that because there's over 200 symptoms associated with long COVID. You're almost saying that a huge collection of those symptoms are part of the whole post-exertional malaise spectrum. My impression was that you have post-exertional malaise, which has a specific cause, brain fog, which has another, headaches, another, etc., so forth. But you're saying that it could be part of the same pathophysiology, i.e., disease-causing process, all under the umbrella of post-exertional malaise.
Yeah, so there are lumpers and there are splitters. And I think the splitters have gotten out and cataloged the symptoms that are associated with post-acute sequelae of COVID-19 or post-COVID condition, or however we want to call this umbrella phenomenon that we see. But as I read those first works by Hannah Davis and her colleagues, starting to catalog those 200 symptoms, I saw tons of commonalities with regard to what we've seen for many years with MECFS. So yeah, interestingly enough, one of those 200 symptoms is post-exertional malaise or post-exertional symptom exacerbation. I don't really think about that as its own symptom. It's its own cluster of signs and symptoms. And I think one of the things that impairs clinical identification and even research into this post-COVID condition, this post-acute sequelae of COVID-19, is thinking about post-exertional malaise as its own thing. In fact, I think the term that is preferred in the patient community among people living with long COVID is post-exertional symptom exacerbation, which is part of the international consensus criteria for ME, just meaning that symptoms are exacerbated with a prior exertion. But that's just one component of post-exertional or immune exhaustion, or what's commonly known as post-exertional malaise. So I would encourage us to start to think about these signs and symptoms less as individual things affecting individual systems and organs, and looking at these commonalities that can be really critical for people's quality of life.
So I've asked this question several times with several interviewees because the Canadian consensus criteria, which was developed in the early 2000s for MECFS, closely matches the presentation of long COVID. And I've asked as to whether, from Dr. Amy Kroll and Professor Danny Altman, whether as a result, these are one and the same disease. What's your opinion on that?
I think there's a lot of overlap. My sense is that they aren't precisely the same disease. So there are a couple of things that lead to that. The first is that the precipitating pathogen is known and potentially different. I have a hunch that it causes a very similar pathophysiologic cascade. But I think if it's caught early enough in the process, preventing that process from moving forward is going to depend on the pathogen. That I think that's a pretty common thought in the viral persistence community. My sense is that we may be catching the process too late. Once a person has post-exertional malaise, it strikes me that this is a different process that can't fully be explained by viral persistence. And I think the literature backs me up on that. I would also say that the way we have defined post-COVID condition, post-acute sequelae of COVID-19, opens us up for a host of different conditions under the umbrella involving end organ damage that would not necessarily be subsumed under the Canadian consensus criteria. So, for example, people who have cardiopulmonary conditions directly related to the pathogen itself wouldn't necessarily fall under the umbrella of having post-exertional malaise. But I think there's some emerging evidence suggesting that there's some substantial overlap of the Canadian consensus criteria and the international consensus criteria, and a healthy proportion of people with long COVID, particularly folks who have a little bit longer duration of disease.
So are you saying that people could be developing two diseases concurrently from SARS-CoV-2, i.e. they could be developing long COVID and MECFS?
Yeah, I think Hickam had it right when he said that a patient can have as many diseases as they darn well please. So I do think that there may be parallel processes or even a serial process in which an infection leads to a common pathophysiological pathway, whether that may be in common, whether you're talking about an initial infection with SARS-CoV-2 or Epstein-Barr virus or Q fever or a number of different infections that have been associated over time with MECFS.
Yes, my understanding from that, and I've heard that from other scientists and healthcare professionals, is that for a proportion of the population, a pathogen, i.e. a virus, a bacteria, a parasite, can be any of those infective processes, gets into their body. And for most of us who experience that, we get sick and we recover and we go on with our normal lives. But for a significant proportion of the population, which can be anywhere from 5 to 30%, that doesn't happen. And the immune system responds in a way with a cascade of inflammation and biochemical processes to cause illnesses like MECFS or long COVID. And depending on what the initial virus, bacteria, whatever it is, will depend on what, and also, I guess, people's genetic makeup, their previous exposure to disease, the environment that they live in, will depend on how their body responds to that pathogen. So there's maybe a range of symptoms that you will get, and then ones that differ depending on what the infectious agent is. Does that sound sensible?
Yeah, I think that sounds very sensible. Of course, we don't have any of those precipitating triggers worked out for sure. And I know that there's rightfully a focus on the immune system and immune dysfunction. But as a physical therapist and as an exercise scientist, one of the things that post-exertional malaise is to me is a bioenergetic phenomenon. So it's almost as though the virus has hijacked the cellular machinery of energy production and utilization. And so there's not enough left over for daily functioning. That's where my research and clinical interests have been over time. I think some important corollaries from that related to how we start to help people who are living with post-exertional malaise.
Thank you. That was a really interesting discussion. I'm going to get back to PEM now. I think you've just partially answered this with your question, but what is the physiology behind post-exertional malaise?
I like to use this analogy, and it's the analogy of the plug-in hybrid car. And so if your listeners have heard this, I think I've used this, I don't know, just about everyone I've talked with, but it's just so handy to understand how the body produces and utilizes energy. If you asked me to explain the function of a plug-in hybrid car any more deeply than what I'm about to do, I won't be able to do it. So I'm just going to warn your listeners now. But plug-in hybrid car has two fuel sources. It has a battery and it has a gas motor. And those fuel sources are used for different uses of the car. So the battery is used for moving along flat surfaces and stop and go traffic. The gas motor is generally used for going up and down hills, going freeway speeds, hauling people, hauling gear, and also it can charge the battery. So you have a short-term, low-intensity energy system, which is the battery, and you have a stronger intensity, longer-term energy system, which is your gas motor. The gas motor in people with post-exertional malaise just doesn't seem to be working properly. So if you think through the analogy then with a gas motor that doesn't work well, what do you lose? Well, you lose the ability to do longer term, higher intensity activities, and you lose the ability to charge the battery on the fly. And so that results in overutilizing the battery, which risks breaking down at the side of the road because you run out of battery. So I think what I just explained was about 20 years of exercise science in post-exertional malaise with kind of a silly analogy. But we use 2-day cardiopulmonary exercise testing to look into the kind of the bioenergetic portion of this disease process. And what we found is that people just don't produce and use energy as well who have post-exertional malaise compared to other disease states and compared to just being out of shape. In particular, the most interesting findings have been at submaximal exertion, where you can't fake it. And submaximal exertion is a really interesting place because it's where we function. If you've gone upstairs and your legs have burned and you're out of breath for a few steps, you've exceeded that kind of submaximal exertion. People just tend to live there who have post-exertional malaise. It's that lived experience of constantly just needing a minute after going up the stairs, except maybe times infinity.
Mm. Oh, that's a great analogy. It just simplifies things in a really concise way and allows you to get a picture of what people are suffering. As I said at the beginning of the episode, and I'm saying it again now, all of the research papers that we mentioned during this interval will be available in the show notes. But I'm going to refer to a piece of research that was done fairly recently entitled Deep Phenotyping of Post-Infectious Myalgic Encephalomyelitis Chronic Fatigue Syndrome. I think this may well apply to long COVID sufferers. It's quite a granular paper, goes into great scientific depth. I think Eric Topol gives quite a good summary of it, but they have an excellent picture diagram of what they feel is this disease process or pathophysiology of MECFS and PEM. They talk about how a pathogen comes in and then lots of metabolites are produced or not produced, which has an effect on the brain. So as a result, the motor system doesn't work properly. So the nerves that the brain talks to fire your muscles don't really work properly in people with MECFS, and the heart and the lungs don't respond as well from this automatic or autonomic nervous system, and that leads to pain. What's your feeling about that paper and their discovery?
Anyone who spent more than 5 minutes on my Twitter feed knows about this paper.
Right,
and how I feel is not as charitable. I think their linkages are highly speculative. I think it's very early. I think they've made some links that are not helpful based on data that's incomplete. This is probably not the example of a paper that I would use to highlight the mechanisms of long COVID or post-exertional malaise in ME. The Rob Vust paper from the Netherlands, on the other hand, is, I think, a really good paper that provides a little bit more focused, a little bit narrower, but still, I think, good quality data that we can rely on to show that there are some changes in skeletal muscle structure and function in terms of the bioenergetics, kind of the Krebs cycle, that are impaired in the post-exertional state compared to folks who are out of shape.
Okay, that's a very interesting perspective. But yes, I am also aware of the other paper from Amsterdam, which I felt was excellent because they took actually samples of muscle, didn't they, from the thigh before exertion and after exertion of people with long COVID and showed that there was damage, which really backs up the fact that pushing people graded exercise is inappropriate, can be dangerous for sufferers. So yeah, I thought that was an excellent paper.
Absolutely.
Todd, how do you diagnose post-exertional malaise?
Well, our data over time has supported that William Osler's old dictum that if you listen, the patient will tell you their diagnosis is true. About 12 years ago, we showed that reports of severe fatigue plus a cluster of symptoms, including neuroendocrine dysfunction, so weakness, immune dysfunction, sore throat, swollen glands, pain, and sleep disturbances, were highly discriminative between people with ME versus deconditioned people. And just recently, we simplified the approach to say, hey, if a person only has one or two unusual symptoms from a whole menu, that's enough to differentiate ME from deconditioning. So just listening to patients goes a long way. And I think the science vindicates us in validating a patient's unusual lived experiences following exertion. But outside of that, there are a number of promising study results that may turn out to be biomarkers. We've seen different types of blood tests, different types of biochemical analyses, and so forth, but we don't have one that's been fully validated for use in a primary care provider's office yet. We've published, as I mentioned, a lot on submaximal exercise dysfunction on 2-day cardiopulmonary exercise testing, along with the symptoms and signs of post-exertional malaise as a marker. And this can be helpful because here in the United States, at least, it's admissible evidence in Social Security disability cases that adjudicate disability, acknowledging that cardiopulmonary exercise testing should be used on an individual basis with appropriate cautions with experienced folks doing the testing and really should be considered on a case-by-case basis.
Could you tell our non-medical viewers and listeners what a cardiopulmonary exercise test is?
Yeah, just put simply, it's a test in which you're on a cycle ergometer, so one of those exercise bikes, and hooked up to an EKG, have a mask and a tube in your mouth that connects to a computer that analyzes the gases that come out of your mouth during the test. We ask you to start pedaling at a constant rate, and then during the task, the bike pedals get a little harder to pedal. So there's this sort of gradation of resistance there. The test lasts usually from maybe 6 to 12 minutes. So that's one type of cardiopulmonary exercise testing. There's a bunch, but that's the kind that we generally use. And then what makes the Workwell Foundation's protocol unique is that we come back 24 hours later and we do the same test. Then we compare performance on the two tests.
Right, that's great. Thank you for that explanation. So my next question really is, as a family physician, I don't have immediate access to something like that. Probably a physiotherapist in Vancouver or department that's able to do that, but the wait list will be a mile long. So apart from the great medical edict of listen to your patient, because you reminded us that 70% of our information comes from the patient history when we're assessing, and it's about listening. Is there other methods of diagnoses that can be applied in the family physician's office that you would recommend?
Well, being a physical therapist, I want to tread lightly here, understanding that being a family physician is not my background. But what I have seen used to great effect is after identifying whether a person might fit relevant case definition criteria for post-exertional malaise, providing validation of that diagnosis, doing things like assessing for orthostatic intolerance, a treatable aspect of the disease, doing testing for mast cell activation syndrome, which is potentially prevalent in this population, being alert for symptoms and signs of craniocervical instabilities or joint hypermobility syndromes that also may be addressed with your rehab colleagues could be helpful as well. So while there is no approved test and no approved cure for post-exertional malaise, there are treatable aspects of this clinical phenomenon that can improve people's quality of life.
So then you're saying that if we try and diagnose things in the office that might be associated with post-exertional malaise, like, for example, I guess we could use a NASA test, and people can also do that at home with somebody for safety. I know for mast cell activation syndrome, doing simple things like rubbing on someone's skin in a particular way can cause a reaction. So that might be an indicator. By finding associated things, as well as listening to the patient in the office and maybe looking at a consensus definition for post-exertional malaise, bringing all of that information together could make the diagnosis in the office. That would take a series of consultations if you're only given 10 minutes to see a patient, or maybe doing a double slot each time. What about the person, the sufferer, keeping a journal of what's happening to them? Does that help at all?
Absolutely. And it certainly helps me as a physical therapist. This sort of gets into what the physical therapist, occupational therapist can do to help. That ultimately journaling serves as a cornerstone of pacing programs, and pacing being balancing activities with rest. Again, trying not to tax the gas motor that's dysfunctional, we've identified already, and trying not to over-rely on the battery. What we see is that there are pencil and paper ways to do it. As simple as just keeping a flip notebook, and 3 or 4 times a day when you remember it, just the time of the day, what you're doing, and how you feel. Over time, that data accumulates. With brain fog, it's really difficult to journal and to keep track of things. But if we can allow the paper to remember for us, then that can be very helpful. And of course, there are apps on the market now that are very good for this in terms of journaling, in terms of pairing biometric data concurrently with symptoms so that people can draw those relationships without having to put in a lot of work to remember what's happening.
Great, thank you. A lot of healthcare providers label post-exertional malaise as being psychosomatic or as a result of deconditioning, i.e., being unfit. What's your response to this?
They're wrong. I think we have ample data suggesting that it's a little like shooting fish in the physiological barrel. There's just so many other alternate explanations that are so much better than a psychosomatic explanation at this point, that thinking that post-exertional malaise is primarily psychosomatic is living back in the 90s, in the worst way, musical tastes aside. As for deconditioning, look, we have ample evidence at the systematic review level that there are important differences between people who are deconditioned and people who have post-exertional malaise. And in fact, I would go so far as to suggest that data means that people with post-exertional malaise do not have a normal metabolism, do not have a normal ability to accommodate and adapt to exercise. And so thinking about people as deconditioned who actually have post-exertional malaise can be harmful. And the harm comes in the fact that if you can't recover from one bout of activity, like washing your hair, brushing your teeth, you're not likely to accommodate going for a walk and then advancing that walk a few minutes here and there, or when you feel like it. And so here again, this is an argument against graded exercise for post-exertional malaise.
Thank you. What is pacing?
So pacing is balancing activities with rest. It's a way to reduce tax on that gas motor, the impaired aerobic metabolism. It's an opportunity for people to make voluntary, judicious decisions about how to use their energy instead of letting their body crash and decide. Now, if you're in the severe range, pacing is hard when the offending physical activity is rolling over in bed. Or getting up to use the bathroom once a day, or having a sponge bath or something like that. So pacing generally is a little bit more helpful in the mild to moderate phases of the disease, where there is still that ability to voluntarily allocate energy towards desired activities.
Okay, so how does it work practically? I'm a listener here, or a viewer, and I'm trying to work out how I can apply pacing to my everyday life. Could you give a practical explanation, and what is the energy envelope?
Yeah, energy envelope it just means keeping activities within your abilities. I think the first step is to acknowledge that pacing is hard work. Everyone thinks about pacing as doing less, and so they think about pacing as less. But pacing actually takes a lot of hard work. It takes a lot of self-examination of one's own activities. It takes a lot of thinking through what a person values in terms of their functioning and the kinds of things they want to do, the person they want to be, and the things they'll want to prioritize. Balancing different types of health concerns, some of which may respond to exercise, but exercise might not be possible because of the post-exertional consequences. I think just acknowledging that there's some setup and some lifestyle modification that's important. And this is where I think the clinicians listening in, rather than thinking about pacing as helping someone with pacing on an episodic basis for a few visits here and there, kind of masked within a certain time period, we need to start thinking health coaching models for people, more prolonged. We need to think about effective models of behavior change, but not to do more exercise, which is what we commonly think of, but to engage in seeking and enacting this balance between activities and rest. As part of that setup, I think we've talked about it a little bit already. Take notes. We've talked about the paper log. We've talked about apps. Getting insights as to the different types of activities and how they may affect your body is really important. Having that data is going to be critical in order to make those decisions in terms of balancing activity and rest. I think consistently when I work with people on pacing programs, it's important to give yourself permission to do less. Doing less is not being less, it's actually being more. in a lot of ways to give yourself permission to feel better. That involves a lot of working against prevailing social attitudes towards what we think about as being industrious, productive, and so forth. It's a lot of unpacking some personal ideas about being worthwhile, even if you were making some short-term sacrifices in the attempt for a better balance. I think as such, building a community around you whenever you can that encourages your pacing, helps your pacing, at the risk of being a little bit contemporary in my reference, fills your cup. I think these are things that are important, but really difficult to do because, as we talked about earlier, post-exertional malaise tends to narrow your social circles a lot, making sure that as much as possible, the people around you are supportive of your lifestyle, I think are critical.
I love the term health coaching. I'm going to use that one. I will quote you, I promise. So can you also explain the practicalities of pacing with regards to heart rate biosensitivity and anaerobic threshold?
Absolutely. So anaerobic threshold is the point at which your aerobic metabolism becomes defeated, doesn't work as well. It's hard to function above your anaerobic threshold. And what we notice is that people with post-exertional malaise, their anaerobic threshold drops after they've exerted previously. So we think this is part of the reason why there's a sort of an up and down or a waxing and waning window of function for people. It's literally because their physiology is different. In fact, when I first started looking at this 12 years ago, they showed me these 2-day CPETs that in the first day person looked totally different than the second day person. And I thought, how could this possibly be? These are two different people. And of course, my Workwell colleagues said, nope, same person, 24 hours different. We don't see that in deconditioning, obviously, and we don't see that in psychosomatic phenomenon either. Again, your submaximal exertion is not something that you can fake. So what we do is we try and find a marker of that anaerobic threshold. And so we select heart rate because it's easy. We think about the submaximal exercise dysfunction as primarily being the oxygen you consume and the workload that you can do at that anaerobic threshold. But heart rate also is an important marker because you can measure it on commercially available wearables. So knowing where your heart rate is at anaerobic threshold is one way to get real-time feedback about your activity intensity and to make decisions within the moment about how you want to allocate your energy. If you're over your AT, it's time to rest. If you're under your AT, potentially okay to continue.
And how do you work out that heart rate threshold?
So we would use the heart rate at anaerobic threshold on the second day of a 2-day cardiopulmonary exercise test. But you can also take your resting heart rate, which is the heart rate that you wake up with. So wake up before you get up and look at your heart rate, add 15 beats to that. So heart rate, resting heart rate plus 15. That's one way to do it. There are some other ways to do that we can put in the show notes, but that the resting heart rate plus 15 is the simplest and it's the most conservative way to think about your heart rate at anaerobic threshold for a pacing program.
And when we talk about aerobic for our non-scientific viewers and anaerobic, can you give some explanation to that? Because it's when the muscles use oxygen and when they don't.
That's right. So aerobic metabolism is your gas motor. This is your long-term higher intensity energy system using fats and sugars. Essentially, you come them in the presence of oxygen. For the clinicians out there, it brings to mind recollections of the Krebs cycle. We all try and block out because it's one of the first very complicated things that you learn, but it turns out to be very important for this. Your aerobic metabolism is very efficient. It nets a lot of energy, but it's only so good for so long because the byproducts of the process end up defeating the process and it's not as good anymore and end up trying to burn those sugars and burn the byproducts of using oxygen to burn sugars and fats. That's at the very end. You do that without oxygen. So that would be considered anaerobic metabolism. Can't do that for very long, and it's very uncomfortable. But it seems as though people who have post-exertional malaise, ME, long COVID, they live in anaerobic metabolism.
Yeah, so the whole idea is once you set that heart rate threshold that you don't go beyond it so that you don't tip into the anaerobic threshold and get
Right.
very ill and regress. So no, that's fantastic. How does a physiotherapist help someone with PEM prevent or alleviate their condition? So I'm thinking about what you do as a healthcare professional practically for people in this instance in your clinics.
Great question. Pacing, and more pacing. Again, a health coaching model is important. This is a lifestyle change. This is a change in how a person makes decisions about their life. Again, for my physical therapist, occupational therapist, rehab medicine colleagues out there, we're not thinking about episodic care. We're thinking about the long term here. This is a long game. In addition, providing advice, reinforcement, troubleshooting, problem solving on some of the treatable aspects of the condition, such as orthostatic intolerance, how to live with orthostatic intolerance, how to live, for example, postural orthostatic tachycardia syndrome, finding the appropriate stockings, how to get the right amount of salt in the diet, these kinds of things that we consistently troubleshoot with people, of ways to compensate or provide splinting, or if appropriate, very, very cautious exercise for people who have joint hypermobility syndromes and so forth. So there's a lot that we can do in order to help improve quality of life, even though we don't have the gold standard testing and treatments yet.
That's great and really positive. We need to clone you. Thank you, Todd, for such a fantastic interview. It's really informative, very enriching. And thank you for all your hard work and advocacy for long haulers and those with MECFS.
Really appreciate the chance to be on with you today. Thank you for inviting me, and best of luck to everyone. Thanks.
Thank you again. And please join us next week for another episode of Long COVID The Answers. Some questions for viewers and listeners to consider. What are your top 5 takeaways from this episode? How will this episode change your practice or perception of this disease? What will you do to act on what you've learned? Please discuss your thoughts on our social media outlets, Twitter or X, the website blog, Instagram, Facebook, or LinkedIn. Please rate this episode.